fixator, Ortho SUV. But I can tell you that he is the most accomplished limb reconstruction and Ilizarov surgeon. There are more than 90 publications on his name. There are more than 15 patents on his name. He has written 4 monographs. We are really honored to have you, sir. I welcome you. The second faculty is none other than Dr. Altaaf Kawoosa. Dr. Altaf is no less. There are 53 publications on his name. He has done many innovations in Ilizarov, and he has huge experience of almost 25 years in Ilizarov. So I welcome you, Dr. Altaf. Our third faculty is Dr. Mangal Parihar. I don't think there is anybody in orthopedic fraternity in India who doesn't know Mangal Parihar. He's a very famous limb reconstruction surgeon from Mumbai. And Mangal is like friend, philosopher, and guide for all of us ASAMI members. The next faculty is Dr. Vasudevan. Dr. Vasudevan is also known for his tremendous work in complex deformities and limb lengthening. But he is also known for his Palakka deformity course. So I welcome you, Dr. Vasudevan. Last but not the least, Dr. Shamsul Hoda. He's from Patna, Bihar. He's a young, dynamic Ilizarov surgeon. And he is also quite active in Foot and Ankle Society. And he is our joint secretary of ASAM India. I welcome you, Shamsul. So without wasting time, let's go for this wonderful academic feast, use of Ilizarov in upper limb. So I hand over the meeting to you, Dr. Altaf. Please take over.
Thank you, Dr. Ruta, for nice to introduce the faculty. I'll be sharing my screen now. So we chose this topic because the upper limb is among the less spoken about in Ilizarov. Most of the time we speak about lower limb, the non-unions, defect non-unions, lengthenings in the lower limb. But I think the Ilizarov technique is equally important in the upper limb and sometimes more important because it involves more technicalities. So how would we apply Ilizarov for the upper limb? This is less commonly used than the lower limb, and one got to be more cautious in case of upper limb because you have the fine motor functions of the hand and the upper limb, and then you have close proximity of various nerves and vessels of the upper limb. And one got to know here that you have a better regenerate, especially in humerus because of its muscular environment. So you got to be cautious about premature consolidation in children. In this my presentation, I would like to highlight a few of the important things of role of Ilizarov in the upper limb to give an overview, so that the subheadings will be taken care of my other faculty. The common indication would be a humeral lengthen that would be needed for an acquired or a congenital deformity. Then defect unions, very common, septic as well as aseptic. Then we have deformities around elbow, which Dr. Vasudevan will be taking care of. So I will not be speaking much about them. And then we have in forearm and wrist, especially forearm lengthening is important. Here, more important is the isolated lengthening, is radial and ulnar, than the full both bone lengthenings, because this gives the discrepancy. So it's very important to lengthen either of the bones where it is deficient. Then there could be deformities, and among them you have really very common ones. You have the growth arrests, or you could use in certain congenital conditions like club hand, which could be congenital or acquired, and could be used in Madelung also. Especially in hand also, we could use it for small bone lengthenings. And then I'll be briefly speaking about some innovative and unusual indications, like we've been using it in neglected Monteja based on the principles of distraction osteogenesis and ulnar lengthening for Kienbock's disease. So we start with the simpler things, like you have humeral lengthening. Just for our junior guys, you got to know that if you got to lengthen this humerus, the reconstruction is simply you could have an Italian arch or an omega arch from the Ilizarov system, And then you could have a 5/8 distal that would allow free flexion and extension at the elbow. And then you have a couple of wires which have to be used in such a way that you take care of the neurovascular system around. And then approximately relatively easier, you use half pins, and that would be in two plates. Then you use oblique posts so that you connect the lateral aspect of the humerus towards the medial side of the ring, and of course with some threaded rods. And you have what could be done approximately distal to the this deltoid tuberosity, or it could be done in the supracondylar region. Going with an example, you see this girl, 6 centimeter shortening of right humerus, and compare the length on either side. Actually, this is post-osteomyelitic fascial arrest. So the conventional plan pre-construct used, like I described earlier, that you have wires fixing the distal fragment, and you have a drop pin also to give more stability. And then the proximal one is attached through half pins. And you have proximal corticotomy. Then once you distract, you watch for the distal neurovascular system and the regenerate. And then you go on modulating the rate of distraction. If lesser than you would, if you have a hypertrophy, you would slow down a bit. And then once the length is equalized, you would keep it for some time till it consolidates. So this is the comparison to begin with. Then once we got the full length, a functionally good limb, and this is the follow-up at 12 years. So a nice bone and continues to have an excellent function at 12 years even. So one of the more common indications of Ilizarov is defect non-union. This is effective in both septic as well as aseptic ones. And you could use bone transport from either metaphyseal region as would be appropriate for the case. Dr. Ruta will be discussing about the infected non-unions, but I chose a slightly different case to speak about here because it has some inherent problems with this kind of a case. This is 3 years old child gapped due to diaphyseal sequestration. So the issues here are the child is too small to handle a ring. Then there is associated porosis. The bone is very weak, and you have the tapering bone ends, and a scar at the defect side. So how would we settle it? So what we did, we used curved connection plates instead of the ring at both sides, and of course connected with threaded rods, and we made it across the elbow so that we could make it more stable. And then corticotomy was done at the supracondylar region. Sometimes we use this intramedullary wire to kind of manipulate the manipulate the transport through this ring. So it doesn't allow it to go anywhere. So it maintains the alignment and your life becomes easier. And no soft tissues come in between the transport. So once this was completed, transport was completed, this went on to unite nicely. So in forearm, you could have the common things is that you do lengthenings of either bone. And the common thing is also that you go for bone transport in case of infected non-unions or aseptic non-unions. Then there are few deformities which can be tackled with Ilizarov also. This is very common. Everybody in orthopedic practice sees this traumatic arrest in case of children. So you have a huge difference in many cases. This could be of varying degree, the amount of arrest, depending upon when it actually happened. So our non-Ilizarov surgeons usually try to think about other than lengthenings. They would concentrate more on the ulna and then fixing in graft and all other things. But we, like Ilizarov surgeons, are confident that if we restore the actual bone which is defected, which has been affected, so we concentrate more on the lengthening part of, so that we could restore that back. So simply, this would be for the beginners also. You have only two ring construct. You may not need much. So the principles here are that you use the rings in the distal area. You fix the wires from radiobolar to ulnar dorsal, and another one is to be perpendicular to that. And similarly, proximally, the fixation has to be distal to the posterior interosseous nerve, and then the wire scheme would be same. And then you could do the corticotomy distally here. So you could add drop pins or wires as you would need, as you would find that this ring to be stable enough. And one has to ensure that there's free pronation and supination. This makes the limb functional. This is during distraction, and here the distraction is completed. So you go on watching the regenerate once you are distracting, and then you go on watching the neurovascular and distal function, tender functions of the hand. So you may over lengthen depending upon how much is the growth potential left in the child. So if the lengthens are event free, you could over lengthen for a while so that the ulna would catch up with that. We have equalized the length, so the distal radial ulnar joint is now level. This is the comparison, how much it was to begin with. Around, I think, 4 centimeters of lengthening was performed in this case, and with an excellent function. So if sometimes people are not comfortable with the ring system, so there is no issue, you could use it on the planar distractor. But here one must know that there should be absolute parallelism in the half pins. Otherwise, this tends to have any kind of rotational or angular deformities. So you distract it. This becomes lesser cumbersome to the patient. So here you can see a brilliant regeneration with a great cross-section made. And here again, we have over-lengthened. Since this distal ulna is still open, till this matched, so this is around, I think, second year of her lengthening, second or third year of lengthening, that is catching up. And at this stage, then what you do, if you have still growth potential left, so we would like to orthodese it here so that there is no further discrepancy. And the most important thing is you got to preserve the function. And I think there are no issues with if your lengthenings has been bookish, and if you have been good enough in monitoring the regenerate, monitoring the function, so you don't have any difficulties in anatomy as well as physiology of the limb. So the common things what our common practice would involve is this managing gaps. So this could be infective as well as aseptic. So this particular example, this was post-firearm injury. So it was a 3B open fracture. Initial management involved external fixation because the plastic surgeons managed this flap later. And once he was sent to us again, that time we performed the transport. So we did a proximal corticotomy and a three-ring construct. Three-ring construct we used. So you can see we have avoided the wires in most of these cases. So you could have equally good results with the half pins. And then if they are used in two planes. A wonderful regenerate again created, so you don't have issues. So once you docked it here, we added some little cancellous graft to potentiate the union so that we don't lose anything. And this thing went on to heal nicely. An interesting thing. So you must have come across, this is not uncommon in our country. We have a lot of osteomyelitis still going on. And this osteomyelitic radius comes in different parts. It could have only the distal fascial area left or some bone left, varying degrees of length that radius will be left with. So our concerns of treating this depends on those. Like if you have totally, this radius is lost, then you would concentrate on making it a one bone forearm. Or sometimes if you have, like in this case, this is more of a deformity rather than only a defect. So, and then we understand what are the concerns of the patient himself. Like in our patient, he was more concerned about the deformity aspect of this. So we thought that if we concentrate, she had some movement still possible at the distal radioulnar joint. She could make her hand still functional. And at the same time, then we wanted to preserve this. So I concentrated more on the deformity aspect of this condition. So think about the Cora at this place. So we correct the deformity there, had an initial distraction of the distal radius during intra-op, then fixed through the ulna so that it became one unit. And once we were distracting, then we compressed on this aspect as well, because this is not a typical triangle type regenerate what we would get in an angular correction. So this was managed to have translation as well as correction. So we were able to get a good cosmetic result for her. This axis is balanced. Your distal radioulnar joint is still good, and she still continues to have good function. Anytime she continues to have any problem, that time we might deal with this. But for the time being, she's doing very well. So to compare the initial one with the final one, she's happy about the cosmetic result. Then interesting thing is about lengthening of short tubular bones. Lengthening involves the same principle as for the longer bone lengthenings. So this is less traumatic than other methods. Everybody would agree. So you wouldn't leave any hardware in place after completion of the procedure, and you have predictable results. You don't have to use any grafts, so you don't have donor side morbidity. This exemplified by this patient with short fifth metacarpal. You see from the X-ray. And then this was lengthened by the distraction osteogens. Again, this was made customized from the connection plates only. We didn't have these were our earlier days. We used from this Ilizarov set only. But nowadays we have UMAX distractors that are more effective and more efficient in dealing with distractions. So this is nicely restored, excellent cosmetic result, and an excellent function. So I wanted to make a point here that if you want to lengthen the central ones, these are stable ones. So they don't have usually any issues while distracting. While as these fifth and second would have some kind of angular deformity if they are not tackled well. So again, a low profile distractor used here, and you have an excellent regenerate in making, and the length is equalized. So the point I wanted to make here is like, this is the fifth metatarsal. If you don't have any kind of absolute parallelism in this, this tends to give some kind of a deformity. Though the length is absolutely nice, but there is some deformity, though it clinically didn't manifest. But I wanted to make a point that the pins in case of unipolar distractor has to be absolutely parallel. One important thing is that you don't have any issues with the function, low profile distractor, because ultimately it's the function that's more important, that scores very high than the anatomy. In this case, this is a congenital one. So if you tend to have any loss of the function, it wouldn't be prudent to do lengthening in such cases there. And then I would be briefly describing what could be achieved by using the principles of distraction and osteogenesis. This was an innovative idea. This is neglected montagia. So here you see that this has a lateral dislocation as well as the anterior. This would be kind of an oblique plane. We'll all agree that currently people believe that ulnar osteotomy and radial head relocation, and then angular reconstruction is being done. And then they try to maintain the radial head with transcapular pin. And then this leads to a delay in the rehabilitation. And if you go through the literature, most of the times you wouldn't find great results of motion around the elbow as well as restoration of the radial head into its native place. So the results with these options are not that encouraging. And then what we are encountering many a times are the neglected ones who have been neglected over for a long period of time. Basically, there is something which is called a mismontage. So the child doesn't know. The parents don't know when the injury actually happened. So when they tend to present that time, they are actually presented with the radial head dislocation only. So what we did, we made use of the principles to manage the deformity. So this was based on, I actually built it upon Hiraman's principle, that if you got to hyperangulate the ulna, the interosseous membrane would bring the radial head back. And at the same time, what we would gain is that we would lengthen as well, and that you don't need to have any kind of bone grafts, you don't need to have any kind of plates inside, and the process would be gradual. So there are no issues that would be associated with any distal neurovascular dysfunction. So what is the idea? Idea is that if you have two plane deformity, so I'm concentrating here, you see this is the anterior one, anterior montage. So if you angulate posteriorly, this is got to bring it back. And then if you just at the same time, if you have a lateral one, by creating a lateral middle inclination on the ulnar side, would bring it inside. So two things would happen at one time by creating a differential distraction from the medial and posterior and anterior and posterior ones. For an example, like this was the child I showed earlier, and similarly a touring construct, just place the hinges as per the plan, did a proximal corticotomy. This is to show that creating a wedge inside has restored the radial head back. And this is after 1 year. You see how beautifully the radial head is relocated. So we have been trying, and I have over the years done many of such cases because these are neglected, these are not that common. But believing in this principle, we try to settle these issues with this principle only. And the excellent thing about this is that you don't lose any kind of motion. You don't lose motion, flexion, extension, as well as supination, pronation. You can easily see this. This is, I think, it's self-explanatory. This is Miss Monteja. You have the Mobat's line. Then you see how much away it is. The radial head is located. By simply creating a lengthening hyperangulation osteotomy has restored the radial head back. Then another idea to finish my presentation is this regarding Kienbock's disease. As we all know, include as per the, and this is a kind of an avascular necrosis which has other factors responsible for this disease. And one of them is the discrepancy in the distal radioulnar joint. So those people who believe that joint leveling, in fact, is still one of the methods of settling the issue, because there are abnormal forces, abnormal loading forces. So those who believe in radial shortening and people would believe in ulnar lengthenings. Then because of the problems with the ulnar lengthening, radial shortening became more popular. But then you do have non-unions, and then you still have hardware left in place. So ulnar lengthening went into dispute because it needed bone grafting. There was non-union, was very common, and then you would need hardware, and there was difficulty in exact joint leveling. So we concentrated on this aspect. If this thing could be done without the difficulties of these issues, so we went ahead with this concept of ulnar lengthening with distraction osteogenesis. So we developed it in 1999. So based on the hypothesis that the biological one would be if you create a proximal regional hyperplasia around lunate, this would perhaps increase the regional blood flow. And biomechanical is certain that once you level the joint, the load distribution would be different, and this might settle the disease. And what is important is that this is minimally invasive. You have a controlled lengthening. You don't need any grafting, and you don't leave any hardware after the completion of the procedure. So these are our early days. We use ring for lengthening. Like I showed this previous example, that around 4 mm shortening that was gained by distraction lengthening of the distal ulna. And this is how it was at 2 years. Now the joint is level, and look at the densities of lunate. So if you would compare the previous one you had a point contact of lunate over radius, while as now it's uniformly distributed. And look at the density of two things. So not to only talk about the short-term results. So we have been following them for over 2 decades now, many of them. So this was preoperative, few millimeter sublengthening, low profile fixator, and this is the result at 17 years. Continues to have an absolutely nice function and a pain-free wrist. This is the function. So what I would like to conclude is that all areas of upper limb can be dealt with effectively with the Ilizarov technique. And the principles of distraction osteogenesis may sometimes be more, you may have more applications in future. Thank you very much for your attention. I think I made some points regarding this upper limb lengthening. May I now request, I think maybe we will be taking questions at the end, if all agree. And may I now request our foreign faculty, Dr. Viktor, for his presentation on 6-axis deformity correction of the upper limb. Over to you, Dr. Viktor.
Hello, everyone. Thank you, Doctor, for invitation. Doctors, for invitation me here. It's a great honor for me being here from Russia and discussing upper limb deformities. And I will speak. One moment, I will show my screen. Is that clear? Is that seen my screen?
Not yet, sir.
Not yet.
Not yet. One moment. One moment. I will show my screen. One moment. I will try. Oh, here it is.
Yeah.
Okay. So I will speak about 6-axis frames and 6-axis correction system for upper limb. Actually, there is a question. There are so many hexapodic systems. Some of them are working on the base of Gulf-Keppel platform, and you know our Ortho SUV frame that is working on the base of its own platform. So all of you in India and abroad, you know the peculiarities of this hexapodic frame. They are made, it is just, for my understanding, it is just a unit. It is unit that will help Ilizarov frame, circular frame, to make very accurate, very precise deformity correction. Dr. Altaaf in his speech, Dr. Altaaf Kawoosa in his speech, he had shown us that Ilizarov frame can help in nearly all the kinds of forearm deformities or upper arm deformities. But as for my understanding, there are some problems that can be addressed by the 6-axis as well. For example, you know Ortho SUV, you know that it can be fixed to any rings, for example, Taylor rings, Ilizarov rings, and other rings. So it is a unit, as I told you, it is a unit deformity correction software-based unit. So it can be used in many various indications, femur, lower leg deformities, joint stiffness. And today we are speaking about upper arm and forearm. So the questions that I want to address myself is, when do we have to use 6-axis frames for deformity correction in upper arm or forearm? What are these indications? Which limitations do we have when we want to use 6-axis? And what are the differences for application of 6-axis frames in upper extremities and lower? You see, these schemes are well known for their their reference lines and angles. They use mechanics. All of us know what is fora. And when we are treating lower extremities, when we are treating femur, when we are treating lower leg, we are starting our treatment, we are starting our treatment from these schemes, and we are finding fora or multiple foras, and we make our plan according to the reference lines and angles. And what do we have in upper extremity? We have mechanical and anatomical axis as well. What do we know about the angles? We know this angle for the frontal plane. We know that angles for the frontal plane for the distal humerus. And we know this for the sagittal plane for the humerus. Does anyone from us, do we use these angles? Not always, I think. What about the forearm? The forearm also has some lines. It has some curvatures. It has some angles. What we usually use? So what I want to tell you that in most cases, when we are treating forearm and upper arm, we are still a century ago, before reference lines and angles. We are making our visual, and of course, sometimes some of us, I don't insist, but not so usually as in lower leg, in lower extremities, we use the reference lines and angles. That's why the same is with the 6-axis frames. The 6-axis frames, they are made to make precision, to make our correction precisely. Here are two cases. They are nearly the same cases. Here is a girl, 15 years old girl with sequela of osteomyelitis. She has shortening, she has deformity. And here is a boy. Here is a boy, 13 years old boy. He also has consequence of osteomyelitis, gematogenic osteomyelitis, and he has shortening of 13 centimeters. So will I treat, are these deformities equal, and how will I treat? Can I treat them with Ilizarov, as Dr. Altaaf had shown, or I will use some kind of 6-axis correction in this case? I don't know, but I am Ilizarov surgeon. I start with Ilizarov. So in this case, what I make with this girl? So she has shortening, as you see, she has deformity of the proximal humerus. So I think that the deformity is too proximal, and I make, what I will make 2-level deformity correction. So I will make correction at the upper level. I made osteotomy correction here, acute correction. And here I made osteotomy for the lengthening, and you see I made a frame on the base only of half pins. It is half, all of these are half rings, and I make lengthening, and I receive good result with good alignment, as you see. And here is the functional result. A year later, she has a very good function, and she is very happy with her lengthening. And the same case, as I told you, a 30 years old boy, I also make 2-level osteotomy. I make correction from the upper level, and I make lengthening at the middle third, at the level of middle third. And what do I have? I have deformity of the regenerate. So I have half ring, so it is like monolateral frame. So I receive deformity. But I have a unit, I have 6-axis unit. What I make, the regenerate is still not strong. So I put hex support. It is not a surgical procedure. I just add hex support to the existing Ilizarov, and I make calculation in the software. And the software shows me where I will bring my bone fragments, how I will move it. So after correction, I have a very good alignment, and I get back to the half rings with the hinges. And that is the result. That is the result that I have. And here is the X-ray result. So very good alignment. So I started with Ilizarov, but I had a problem. I had a deformity, and I used my 6-axis unit, not frame, but unit, to help me with the correction. So in this case, it helped me. And here is the case of, I think it is complex deformity, because we have not only a deformity in the frontal plane, the same gross areas, we have deformity in both planes. So it is a good case to apply 6-axis from the beginning. So I make 6-axis frame, I make osteotomy, and I make calculation, and I show the bone fragments. You see, this is yellow is initial position, red is where the bone will be after correction. And here I use the referent angle and referent lines. So this angle is known, and I make it the same with the lateral view. I want this correction, and I make this correction. So you see, finally it gets here, and here is the alignment. And here is the result. And this is a year later. That is how it was, and that is how it is now. So I think in this case, it is it can be discussed. Of course, I can make in this case, I could make acute correction and lengthen because it is a child, but I do prefer to make correction calculated from the beginning and then made according to calculation. So in this case, 6-axis frame helps me. But you see, the traditional ortho SUV frame is rather bulky for the forearm and for the humerus. So now we do have pediatric ortho SUV mini, ortho SUV pediatric frame that is much more smaller and much more smart. You see how it was for the forearm from the left side of the screen, and you see how it is now. The same with the shoulder, how it was bulky, how it was heavy, and now we can use this small frame, and that's why it brings changes in our treatment. You see, this is a very interesting case. The girl is 2 years old girl, and this is also hematogenic osteomyelitis sequela. So what we see here, we see a small part of the radial bone, and here we see some bone here also, and here is the defect. But I can imagine, I see that I have a wrist, and I know that here is epiphysis. This is still not ossified because the girl is 2 years old girl. So what do I want to make? I want to make one bone forearm, but how can I do that? I will show you why I do need hex frame in this case. I fix the bone that I see by the wire with the thread, and I fix the wrist and the hand. And I make hex frame, and I make calculation. So what do I want to make with my bone? I want to, this is yellow, the initial position. And then I go here, I make some lengthening, and then I move where I need. So I make 3 steps. And I bring the bone with the hand. I bring the part of the radial bone to the ulna. So I made motion by the radius, by the distal radius, so it was brought to the end of the ulna. And after I see alignment, I make fixation by the KY openly. What I see after I remove my KY, one bone forearm. And here also lateral view. This is after KY removal. And what I see later, it is 1.5 years after the surgery. So here is the growth place, and here is the growth place. So very good result, clinical result. Here is the congenital, the radial club hand. So what can I do with this wrist, with this hand? I make 6-axis frame, and I bring, you see the calculation, lengthening, correction, lengthening, correction. So there are a few steps that can be calculated in our software, and I do bring the bone where I need. And it is nearly the same as the previous case. So I make correction, and I fix it by the K wire. And I receive that result. And then I remove the K wire, and in a year after K wire removal, I also still have the hand, the wrist at its place. Another case. This is the case of mother lung deformity at a 16 years old girl. So I also think that 6-axis will be very helpful for me in this case. And I use Ortho-SUV, pediatric Ortho-SUV for that aim. It can be used not only in pediatric cases, but also in forearm and in foot at adult people. So you see, I made osteotomy and I make this calculation. So first step is lengthening, second step is correction. Red is what I need to receive after correction. And that is the result of correction. And that is after frame removal. And that is, she came to me just a week ago, and these are the X-rays AO after frame removal. And which cases do we need 6-axis? For my understanding, which cases do we need 6-axis? In such a case, I have congenital case, and he has elbow joint contracture. He cannot make extension of his elbow joint. I was a little bit afraid to make any frame in this case. I made release, of course, I made the soft tissue release from anteriorly with absolutely no effect, no positive effect. And I decided to make external fixation for that case. So I made this frame, and I made calculation. You see, this is how step by step, from yellow contour to red, and then blue, gray, gray, gray. So all of these contours, these are the steps in the software. So how I will make step by step extension in the elbow joint. So I see my plan, I see what I want. And it is finally how I could make this extension. Very well extends. Now, after that, I made orthosis for 3 months and physical exercises. So the extension was full, and that is the result a year later. You see how he is working. Of course, he has not full function, he has not full extension, but now he has good work of his elbow. And that is all what I wanted to say. Now it's time to answer. I will answer the questions that I asked initially. So is 6-axis required? For my understanding, yes, 6-axis is required in some cases. Of course, not in all cases. The indications for the hex supports in upper extremity are the complex deformities and joint stiffness. Of course, hex supports, they have some limitation. Of course, they are bulky as all the circular frames. But you see, if we use Ortho-SUV, pediatric Ortho-SUV, some of these problems are solved. What are the differences in application of 6 frames in upper and lower extremities? I see no difference at all, because we have to make good alignment in lower extremities and in upper as well. Of course, we are not working on our upper extremities, but good alignment is, I think it's essential, it's necessary. So the take-home messages from my talk are, so Ortho-SUV can be used, all the hex supports can be used in upper extremities. 6-axis frame are very useful in complex deformities and joint stiffness. And pediatric frame can help us in many cases. So thank you very much.
Thank you, Dr. Viktor, for a wonderful presentation. You see, in case of both Ilizarov as well as the hex support, I think everybody will agree that most of the part in surgery is its planning and the follow-up. Actually, one has to be very confident and one has to be sure about the science of your deformities. Then only one would be able to apply these principles. So this is the most important thing. Now, I think there will be many questions from the panel as well as from the viewers. So I think we'll be taking them after we finish the presentations. I think that would be the idea. May
Altaf.
I? Yes, sir.
Altaf,
Sir,
if I may interrupt, I
please,
think
sir.
if you keep the questions after the presentation, it will be more relevant because the presentations will be different. So now you take questions for you and Victor, because
Okay, that's fine.
otherwise, you know, that it remains relevant.
Agreed, sir. Agreed, sir. So we have a question for Dr. Victor from Dr. Rajiv Cole. So his query is, for the distal radius case, it's very difficult to visualize the joint line with so much metal around and small size of the fragment. Do you recommend use of carbon rings in such cases? This is for Dr. Victor from Dr.
Yes.
Rajiv.
Thank you for the questions. For the question, of course, I do recommend, and you see there are some tips and tricks that I can use when I see no joint. Of course, if we have the radial-lassant rings, it will be very helpful. But there are some tips that I can use. I can leave Ilizarov connections. I can place hexapod, and then I remove the struts, but I save the length of the struts. I have only joints, and I can make calculation of the struts joints. So that is how there is, this is very specific tip and trick, but actually it helps because I don't need to have all the hexapod between the rings. I need only the joints to be there, and I can make calculation only due to joints. It is, these tips, they really help. And of course, it is very helpful when we see the joint, so radial-lassant rings, and also while inserting the half pins and K wires, we have to make angulation to the joint by them, and they can help us to make calculation, because if I know that the K wire is going with the angle, which specific angle to the joint line, and when I see this K wire, I can take it for my landmark for planing of the correction.
Thank you, doctor. I have a question now. Like you see, you showed a couple of congenital conditions, like the 114 arm in club hand, and couple of young children which were dealt for deformities. But you see, at the end, you had 114 arm which has an active physis from the radius as well as from the ulna. So the result is at 1 year. What is going to happen after some years? Do you intend to modulate the growth of these two ends?
You see, each half a year I make X-rays for her, and now for me it is. You see, I was. For me, it was something like experiment, because you see, no one knows how it will grow. 1.5 years after the surgery, it is still growing by the same rate. If I will see that it will go to radial or ulnar side, I will try to make something from that.
Because what I was observing, that it's in your first 1 year follow-up, the radius and the ulna have started growing in a divergent way. So would you address it now, or would you address it maybe at a later stage?
I think no. I am waiting. I see no problem now. I see no problem now. If you want, I can get back with the demonstration. I will show you the screen. Yes?
No, not needed, sir. And then third question is regarding the made-lung deformity. Yeah, you see, I also did made-lung deformity with simple Ilizarov also with nice results. But the only concern is that your disruption is in the radio-ulnar joint as well. In your case also, once the radius was corrected, but your ulna was totally dislocated.
It is mother-lung deformity.
Yeah, I am speaking about the made-lung deformity. So does it need to address that thing as well? Because it's a complex joint.
You see, it is very complex joint and very complex question, because I was thinking about this mother-lung deformity, and there is no solution, because in some cases, no solution. I thought about this ulna. I was thinking about that. And I thought to make some stabilization of this joint by maybe by some tendons. There are techniques that can stabilize in post-traumatic case.
Maybe
But
that
you
would
see-
be a prospect to the management. For the
Yeah,
time being, you have addressed the radial part of it.
You see, I was thinking about that to make the stabilization by the tendons,
Right.
So to pass the tendon through both bones. But she has no pain,
Okay.
and after that we can receive this pain. And in mother-long deformities, the hand surgeon, I'm working in the team with the hand surgeon as well. Sometimes they resect the proximal bones of the wrist in such cases. I don't know the better tactics in this way, but for my understanding, what I had shown for nowadays, it is very good. I am still observing these patients. I have
Right,
few
sir.
cases of that, but I have never made stabilization of the distal radio-ulnar joint, and I did not make this resection procedure as well. So if she will have pain, I will think about that and I will report later.
Dr. Mangal, sir, all wants to ask a question.
Yeah, my question to Victor and to everybody is Madeline's actually the 3 or 4 that I have treated. I have found that they don't really have a problem with function. They are able to use their hand very well. What they come with is really the deformity, and they want that deformity. Now, and when you look at them, the ones that I have seen, you know, at 17, 18 or older, they've got a very, very sloped radial sort of articular surface. So the only thing that I have done in association with Dr. Sudhir Warrior, who's the hand surgeon, we decided that we are not going to do anything to the radiocarpal joint or to the radio-ulnar joint. We are just going to get the whole thing aligned, because when they are looking down like this, the problem they have is excessive intercarpal motion. The lower end of the radius is looking like that, but their hand is still straight, and that comes from the intercarpal joint. So the moment you straighten that, the problem with the intercarpal joint goes away in terms of the pain, etc. And so visually they become better, cosmetically, and function-wise they have been okay. They've really come. They've never come for a poor function. They have come for the deformity.
Yeah, agree, sir. We published it, I think, some 16 years back. We had 2 papers on midline deformity. And then,
have you seen such patients elder than 35, 40 years old?
Yeah.
The mother of this girl, she also has both sides mother-long deformity. This is Larry-Weil syndrome, both they have. And you see, her mother is 42, 43 years old, and she had never been operated on. She has worse deformity than the girl has now, had before my surgery. But why did she bring her daughter to this surgeon? Because she says that she cannot walk. She has bad function and she has really pain there. I was thinking first to treat the mother and to make arthrodesis of the joint. But you see, she has pain, but she has to walk. She is walking through her pain, but she cannot go for the surgery. That's why she brought her daughter for that. And let's see what will be later.
Do we have any other questions from the panel?
No, so Altaf, you published 16. Now he just gave us a long-term follow-up that they do develop a pain. What was your paper about?
So my exactly, sir. Same thing was that I did for, like you said, that I did it for, because those were my enthusiastic days of correcting every sort of deformity. So I did it for cosmesis. I was thinking kind of guilty that did I restore everything? But like Victor said, and like you said, that their primary concern was deformity, and I was very successful in that. What my concern was always that it is basically if you take as the distal radius physis, the problem it made like it's very complex. It's only the ulnar aspect of the physis that is deficit. So it is not a uniform thing. By rotating it, everything would fall in place. So that would make me little concerned that how it should be actually corrected. But as you said and Dr. Victor said, that correcting the deformity and then if they continue to have good function, I'll go for it.
Right.
So any questions for my presentation then before we would go with the presentation of Dr. Mangal?
Just a small question to you, Dr. Altaf.
Right, ma'am.
In the metacarpal lengthening,
Yeah.
do you fix the adjacent metacarpal proximally?
No, not
No,
needed.
never?
Like I said, I have a good experience of that. I have been doing it for the last 10, 20 years now. Like I said, in the middle ones, they are inherently stable. Like
Yeah,
if you see even the metacarpal fracture, they
especially
are.
the small one.
No, I mean to say you have the between third, fourth, they are stable on both sides. So you have but absolute parallelism in the fixator so that they don't go here, they don't go anywhere during the distraction. I really did not need to fix them because small kids and then you have this small threaded screws, small shank screws, small low profile. And so I never had an issue. Wireless, especially in this and this, you got to watch for that any angulation. They tend to have angulations. So you have to maintain that this is not inherently that stable. So you might need to take care of them.
Okay.
So any other questions? I don't think we have any questions from Dr. Ravi. Do we have any questions from the viewers?
Not yet, sir, not yet.
Okay, sir. Then should we go ahead? May I request Dr. Mangal, sir, the most experienced of the Ilizarov surgeons in the country, to have his presentation.
Okay, I'm going to just show you one case, just a little bit of more of a technical thing, I think, rather than, I think many of us know that with the exostosis of the distal ulna, you have poor growth of the ulna. The radius continues to grow, and then you can get a dislocation of that radial head. So this 13-year-old came to us with this kind of X-ray. Right? So there was clearly a exostosis over here, bowing of the radius, and a radial head which was prominent and painful for her. So that's what she looked like when she came. And really speaking, she came for this sort of thing poking out and the bowing deformity. She was a precious child born out of IVF. She's actually one of the first IVF kids in the country from Indra Hinduja. She had restricted function also to a certain extent, but she was able, I mean, she was doing all her other work in terms of use of the hand. So this would probably be a Masada type 2B with exostosis on the ulna and a dislocation of the radial head. But the parents claim that this has been there from very early childhood. So my plan was excision of the ulnar exostosis, of course, correct the deformity of the ulna, and lengthen the ulna, and then pull the radial head down, not with the aim of relocating it, just reducing that sort of cosmetic prominence. Now, so she had a significant bow, and I find, at least for the ulna, and when I only want to tackle the ulna, it's pretty easy to use a monolateral fixator. So you can put it perpendicular to each segment, do the osteotomy and get your acute deformity correction, rest that for a little longer instead of 7 days, probably 10 days, and then distract at a slower rate, and there's no real problem with regenerate formation. Of course, for these small bones, we use thinner pins, that is the 4.5 to 3.5. So, and this you can't use the way you normally use an LRS, where you use it with the rail. So here, what we do is keep one clamp above over here and another clamp below, and the pins go into that segment. So the two clamps are kind of angulated to each other. Once you do the osteotomy, it all comes parallel. It's small bones, important to get these right in the center. So generally here, what I tend to do is use a K-wire and then drill onto that with a cannulated drill bit, so that I can ensure that I am in the center of the bone and I don't, stray in different places. So once the osteotomy is done and the pins are got parallel onto the rail, you've got your deformity corrected. And that's what it looks like. So the bow of the ulna is gone, but the prominence of the radius is still there. So we distract it till the ulna starts almost contacting the carpus. And then once it's at that level, I want to tag the radius to the ulna, which would be easy with an Ilizarov, not so easy with a monolateral frame. But here what I did was use a screw and a wire to combine, to sort of capture the radius, something like that. So there's no place for two screws, but one screw and one wire was good enough to allow the radius to be pulled down while the ulna was lengthening. So now as we pull it down, if you see there earlier, the radial head was way up there. As we continue lengthening, the radial head becomes less prominent. And rather than the X-ray, I was using the clinical appearance as my guide, because this is not going to relocate and give her any kind of, she was already stable in that sense. So in the consolidation, that's her at fixator removal at 2 months. And at the time of removal. So this is somewhat like, Ilizarov hip replacement, hip reconstruction, in the sense that the X-ray may look wavy, but as far as the visual appearance goes, they're pretty straight. That's 1 month, 6 months. And the interesting thing is, limb is, yes, shorter, but it's now straight. She has gained extension to a certain extent. Part of it is, of course, correction of the bow, but also important is she's also improved her flexion. Possibly improved a little bit of her pronosupination also, but certainly flexion is better. So rest of all the other movements are perfectly fine, and that's I think at the last follow-up that we have for her. So the kind of points I wanted to make here was, yes, for relatively straightforward things where, as you pointed out, if you can understand what is going on and understand what is the deformity there, you can also use a unilateral fixator for relatively simpler deformities. Complex, 3-axis movements, then you need a hexapod. But here, where I just need to correct the ulnar bow and do a straight lengthening, a unilateral fixator also for most cases of these exostosis will work. That's it.
Thank you, Mangal sir, for an excellent presentation. This is like you made the point again that if you understood the deformities well and planned it well, then certainly the result would be definitely great. My concern still, like we have been discussing previously, and you were annoyed with me also, that maintenance of the middle regenerate. So in the younger people, you see, at the end of the day, the regenerate it had remodeled, was straightened. But dealing with ones you have in, I didn't think that it should happen that the regenerate goes kind of deformed in case of a rail fixator. Do you intend to do with anything with that, Dr. Mangal sir?
Sorry, what? If it gets deformed?
Yeah, the regenerate. You see, like we had been discussed in our previous meetings also, that many a times see the regenerate is going, you go on lengthening, despite being a unipolar fixator, but some kind of a support is not in between, and the regenerate tends to bow. Like in this case, that since she was a child, she remodeled it, and the end result was absolutely great. But in an adult age group, you might not have that. Would you like to do?
In her case, the regenerate actually has not bowed. It is we have corrected that sort of deformity. So therefore, it looks like a bow. It's not a deformation of the regenerate as you would see otherwise. But if I have a poor regenerate, in some cases where there has not been so much of a deformity, and I have lengthened the ulna, there will be situations where the regenerate is a little wasted, or I'm not satisfied with the quality of the regenerate and worried that it will, break or something. I have no hesitation in putting in a tens nail, right? Which is very, very straight. So we take off the fixator and then put in a tens nail to protect it. And because this is more to sort of prevent displacement and things like that, even a relatively thin tens nail works.
That was my point. Like you see, I showed in the child that's why I put in a K wire in between to guide the regenerate to its destiny. So that was my point. So Dr. Victor wants to ask something.
Yeah, not far ago, I had nearly the same case. And the problem that I faced with, and I could solve this problem, is that radial bone is not only long and deformed like both, it is also distortion. It has torsion.
Twisted.
And that is the problem. And that is why here, pronation and supination, you receive good result, but it is necessary to address and to make osteotomy, derotation osteotomy of the radial bone. And in this case, I think it will be helpful for you in this case. I think you'll have to make derotation of the radius and to make some shortening of it, because some subluxation, it's great regenerate that you could make. But in this case, you still have some subluxation. And if you will make some shortening of the radius bone and some derotation, you will have very good function finally. It is great what you did, but I think you will have to get back to this patient.
No. 1 sec, Victor. You're talking of subluxation of the radial head?
Yes.
No, but if you look at the radial head,
radial head is never that inapplical that you would like to get it back.
It's not going to come back into any form of function, and that's actually the reason. 1 sec, let me just show you that radial head again.
It will be interesting to see once again.
See, this radial head, even if you put it into place, I understand.
It is luxation. Yeah.
I agree it is lux, but what I'm trying to say is I left it out on purpose, because if you try to put this head in with this capitulum over there, this is not going to be a normal radial head. That is the premise that I went into it. So yes, there may be some rotational listing, but in this particular case, looking at that radial head, which was lying outside for at least about 10 years, the parents say that this prominence has been there for a while. I was not interested in getting it inside, unlike say the cases which Altaaf showed, which is a Montegia, which has come out, or something which has, I have other cases where even for a few years when they are out, that radial head is deformed, so there trying to put it back is going to be a really, let's see if I can show you this one.
I don't think so. That
Now
would be a
look
desired
at
one.
this radial head. It's so, it is so big. Trying to put this back into position is not really going to improve function. If anything, that would give rise to pain. This is not a normal radial head. The moment it's lain outside for some time. So here again, this is more of a cosmetic correction, and whatever rotation she has maintained that rotation. That's the point I'm trying to make. This is not a normal radial head. This is expanded. This will never become normal again. If someone else wants to, has a comment on that.
Sir, Dr. Mangal sir, nobody would actually like to have that deformed head back into its position. I agree with you 100% with that. Yes, like Dr. Victor pointed out, rotation issues, they may be tackled, but you can't have this deformed head back into its anatomical position to restore the function. The idea of restoring it should not be there.
And
I agree with you.
One moment.
Restored it would have become very painful.
Painful, more painful.
So
one would have needed to excise it. Yeah. Or else one would have needed to excise it.
Yes, or you could excise it, yes.
And one more thing, to protect the regenerate, not to make curvature this regenerate. Nowadays, there are so-called slims. You see, initially there were only fascia dual nails by Pega Medical, and now they do have slim. They have a very good thread from the upper end, and it is straight nail. It's very good. I used it in such case, and it helped me a lot. So I have no curvature of regenerative ulna at all. So it is the second point that I wanted to tell.
So that's like it's like a tens nail with a screw at the end.
You see, it is nail and it has thread at its upper end, like fascia dual, but without female. It is only a male with a thread, with a big thread from the up. It goes through the ulna.
Yes.
And it makes, so I make regenerate and I make nailing. It is pediatric nails. So it helped me in such a case, and I was happy with that.
Even with the tens nail, there is a additional screw which is available, which you put in the nail and then you thread the screw onto it. It prevents the nail from backing out. It's not a part of the nail, but it's a sort of additional, like a cap, you can say maybe.
But
so we use that if required.
But when we have regenerate and we use their titanium elastic nails, they can go through the regenerate and break it. When we have a rigid nail, it will go by the straight way. It's very it is just my tip that I use.
I think that we may have further questions at the end. Meanwhile, I think if there's
there's one question from YouTube. May I? From Mangal sir. Yeah, it is from Dr. Rajiv. Call for Mangal sir. Do you also do or recommend an epiphysiodesis of the distal radius at the end of procedure to prevent recurrence of deformity?
No. I think I've got a boy now who I corrected about 5 years ago, and that fellow was in his growth spurt, and he kept growing. I had equaled his ulna, and after that he kept growing. So his radial bow has worsened a little bit, but I think primarily it is the exostosis and whatever tethering occurs from it. But I will keep them under review, and if required, I will lengthen the ulna again. I don't think doing an epiphysiodesis of the radius is a good idea. It's much simpler to just keep lengthening so that his radius will grow normally. Otherwise, he will have a short limb. lengthening the ulna is not a big deal. So if it's getting worse, then just do a second lengthening of the ulna. That's it. I would not do an epiphysodesis.
Thank you, sir.
Thank you, sir.
May I request Dr. Vasudevan for his presentation? You'll be speaking about deformities around elbow.
Good evening, all. I think it's clear for all, no? Slide is clear.
Yes, sir. Please go ahead, sir.
Yeah. So my topic is Ilizarov in deformity around the elbow. So the indications are, with the emergence of latest LCPs, the indications are coming down. So I prefer Ilizarov in complex corrections, and when lengthening is needed, and when the fragment is too small to fix with a plate. So deformity is usually assessed by drawing mechanical axis. So far, it is not very well standardized in upper limb, as in lower limb. So what I do is I take a normal opposite side as a template and plan it by anatomical axis and joint orientation line on the normal side. And then I reproduce it on the abnormal side. Superimpose the image of the left side or whatever the opposite side, just flip it out and you get the other side. Find out the magnitude of the deformity, find out the cora, chart out the plan of action, and make a pre-assembly. For example, this case, this patient has a cubitus virus on the left side. So I took X-ray of both sides and I measured the, that is a mid-aphasia line, joint line. I measured this angle. It was found to be around 86 degrees. So I draw the same line there. And the distal anatomical axis, the 86 degrees there. And this was found to be the magnitude, 30 degrees. And this is the cora. So this is, that exactly falls onto the epiphysis. Now, conventionally, it has been characterized by a French osteotomy. So with the cora in the epiphysis, but the problem with French osteotomy, it's an open procedure, a poor correction, and you need implants and implant removal later. And French osteotomy creates it makes a new deformity, like because the cora is there, and the osteotomy is at upper level, and ACA is there, so it produces a translation. So it comes like this. So that is a deformity. You can see the lateral translation. And then when you superimpose the film, you can see the translation well. Because it is based on the osteotomy rule 3. It creates a new deformity. Generally, we don't do osteotomy rule 3. We used to do osteotomy 1 or 2. So this is a dome osteotomy, which is otherwise known as a focal dome osteotomy, with the cora around the real, the arch around the real cora. So here this is following osteotomy rule 1. You get the correction. So it actually follows osteotomy rule 2. You can see the osteotomy at a different level and with a raw dome around the real cora. So you get the correction in a perfect correction there. That is a focal dome osteotomy. The problem with the focal dome osteotomy is difficult to do the rotational corrections. Now coming to Ilizarov, it's a closed procedure, no implants and very minimal scar. So do the osteotomy at a different level with the cora and ACA at the real cora position only. You get the translatory correction based on the osteotomy rule 2. You get perfect position. So this is a cubitus virus, the same patient, that was his X-ray with the magnitude of 30 degrees. So this is how that on-table flexion is allowed. So what I did is, instead of doing a 5/8 ring, I used 2 rings placed together so that it makes much more stronger than a 5/8 ring. And you can get a full extension there. This is the hinge. And the corticotomy is done there. This is a distraction rod. You can see the osteotomy line. This is my fixation module, like 2 leaves from oblique wires and a horizontal wire. This is my hinge, little bit of lengthening hinge and a distraction rod here. See, it is getting corrected and an intentional translation is happening. You can see the regenerate in that position. See, this is how the patient is flexing extension with the frame. And just before, few days, 6 weeks before removal, afterwards I removed it, this before and after. That is the correction, extension and flexion. So this is another case where I have a varus deformity in the distal humerus, plus is a stiff elbow, FFD. This is the maximum elbow movement possible for him. And with this is the deformity planning I did. The axis planning and found to be 39-degree varus. And that is his full flexion. And that is the extension. So this was his original exercise. I think he was operated 2 times. Went in for infected non-union or some sort of things, and finally came with a malunion. So this is a strange frame I made. So this is for maintaining the 39-degree varus, and this is for the forearm frame with the hinge for the forearm. So my plan was initially to correct the arthrolysis, elbow extension. After finishing that, I'm planning for a bony correction. So this is a frame made for that patient. You can see this is not a working hinge. This is only a holding hinge. It just holds the frame in 39-degree varus. This is the working hinge for the elbow. So you can see this is the working hinge for the elbow. This is the holding angles. So after removal of the implants, so the old incision was anteriorly. So I removed the implant, and even after removal, I could get maximum movement is this. So I found the biceps was contracted very badly. The issue there is now if I start extending his elbow, as the biceps is attached to the bicipital tuberosity of the radius, there's a very high chance that radial head may subluxate anterior. So I must protect the radial head. So I made a small olive wire holding the radius down onto the ulna, onto the frame. So this is the wire which is holding the radius to the frame. This is a hinge for the elbow. You can see I not put any pin in the distal humeral wires. So what I'm doing, I'm using only the proximal this thing. This is just a dummy half ring and did a forearm frame, and you can see that radial head being protected by that olive wire. So while distracting the extending the elbow, the radial head will not subluxate. So this is how I got the correction. You can see the anterior dirty scar. It is extending further. After the elbow stretching, I thought I will do a corticotomy at this level. So at this point, I did a corticotomy of because I don't want the distal fragment to be, because the flexion extension correction can create trouble because of that. So at that moment, I added wires, olive wire, and the horizontal wires, stabilized it. You can see the humeral deformity getting corrected. And you can see the regenerate forming there. And that is the correction. So I corrected the bony deformity later after correcting the stiff elbow, soft tissue. So that is his extension and flexion. So I got it into, I have no aim to get into complete movements, only for serviceable range of movement. That was the extension. This is the flexion. He improved the flexion further later. So I'm showing another case of cubitus valgus. And this is due to childhood trauma and some infection there. You can see a scar there. When I took the X-ray, see, there is no problem in the humerus. The problem is the radial head is abnormal and the ulna was deformed. So this is the normal planning, and you can see the increase there is the valgus, the proximal ulnar valgus. So I recreated the middle line. So this is a normal angle, this is a normal angle, and this is the magnitude. So this is a cora. So I cannot do a osteotomy at the joint level. So I am planning to do an osteotomy here with a hinge and correct it. But the problem is my base is only very, very small. So in this case, I have decided I will put a arm frame with a olive wire for the olecranon and correct the forearm. So it has gone for a little complicated frame. So it was like this. This is for the arm frame. This is the elbow hinge. This is the ulnar deformity hinge. And I have one more male post. I put another hinge here for these two works in a medial varus valgus. This is for flexion extension. So you can see the elbow being flexed like this. So she has a mobile elbow even during the correction. So this is from the valgus, you can bring it to straight, and it can even go into varus. So that is the complex frame made. This is the osteotomy hinge, and the other one was the elbow hinge. So I made the frame on the patient. I put the forearm into the neutral position. You can see these two are now in an angle. So my aim is once this comes into parallel with this, with the hinge around this, so the deformity will be corrected. You can see that this is the elbow hinge, this is the osteotomy hinge. So it is gradually opened out. Now I got it parallel. So this ring and these two rings, this was originally angulated. I got it straight. I got it parallel here. This is ulnar correction. Now after that, I removed the humeral because my job is done. So my humeral frame was removed, and I got the range of movements. Now this is flexion and extension after removal. So it's a thrilling experience with Ilizarov, and it is not difficult. Your gray matter is always active. Hope you enjoyed it. Thank you.
Wonderful presentation, Dr. Vasudevan. Yes, of course, it's the gray matter that's pretty important in these cases. And like your presentation, it goes on to make us more wiser that you need to customize the frames as per the understanding. And again, I go with the same word that one needs to understand the deformity, then you are able to really execute it. And you may not have the bookish system available for all kinds of deformity. You got to manipulate your rings, manipulate your hinges, and have an idea to manage the things. That gives real great success with Ilizarov. Not only following the basics of Ilizarov, but rather you can manipulate and manage it well with your own planning and customization. Do we have any questions for Dr. Vasudevan?
I have. Okay, I'll just make a comment. Oh, you go first, then Ruta, go first.
Okay. In your first case, did you do any open arthrolysis of the elbow, or did you do biceps lengthening? You had anyway opened. So any soft tissue procedure?
Because the whole area was operated 3 times earlier, it was completely scarred. I just did only implant removal.
Okay.
Because there are a lot of vessels, everything there, and I don't want to expose that area.
Did you distract the elbow? I saw in 1 or 2 slides you.
I just kept it. No, not really. A little bit of distraction, I did it. Yes. Joint space opening up a little bit.
Just to prevent it from crushing.
Yeah.
Mandal, you can go.
Yeah, the point I wanted to make was, in addition to all the deformity correction, and in all these cases, the one point which many may have missed was the fact that all his extensions of the frame were designed to improve the stability.
Yes.
When he had a very small fragment distally, he has gone proximal. When he had varus of the humerus and a contracted elbow, he has gone across the elbow to improve the stability. And that also is an important let us say, component of his good result, you know. So that is something which a lot of us tend to forget, that your frames have to be stable. We think of stability in terms of lengthening and stuff like that, but also in these planes, he's shown that, you know, he's got very good stable frames.
Thank you.
Do we have any other questions?
Dr. Ravi raised hand.
Dr. Ravi is muted. Dr. Vasu, I have a question. Like, you see, you have the normal cubitus varus in younger age group. Would you recommend it for them, or you would reserve it for a little older age group? Because even in younger age group, you can manage with different osteotomies. That, like, we have one published in Pediatric Orthopaedics, lateral invaginating peg osteotomy. So you, like your osteotomy rule 2, we can have things done acutely in younger children.
Yeah.
You have a point, like, see, in the older age group, you would like to have things done gradually. Would you like to reserve it for an older age group only, or do you recommend it in the younger age as well?
I prefer it only little the older age group.
Yeah,
and this is a principle which matters. In children,
yeah,
I would like to do in a different way.
Yeah, that's what I'm saying, because you could manage even osteotomy rule acutely in children with an invagination or kind of a step cut osteotomy. That would be equally wonderful.
Geometric osteotomy or dome osteotomy, we can do that.
I do in a child. I would do. Sorry, go on, Ruta.
No, even dome osteotomy you can do in a child and correct it acutely.
Yeah. What I do in children is do a transverse osteotomy, because it allows me to go percutaneous with a small incision, and then use 2 UMEX pins above and below, do your translation, and then you know, jam it in, fix it. And because it's a child, they heal very well. So there again, the most important thing is the smallest scar possible.
Right. So if we are done with the questions, may we?
Ravi had a question,
Sir.
Ravi has a
Ravi has a question.
Just, I have a question to Vasu, sir. Sir, you have commented that in dome osteotomy we can't handle the rotation. So in your Ilizarov apparatus, how you take care of that rotational component in varus or valgus deformities around the elbow?
Yeah, you are, after getting back the length, you can rotate the region rate.
Okay. Once you correct the deformity and thereafter you rotate the region rate.
Yeah. Slowly correct it. In a dome also you can do it, but you have to be a little careful.
That's right.
Also, if you are sure of how much rotation is there, you can correct the rotational component acutely and do the rest of it gradually.
Okay.
But it's usually a problem to know exactly how much rotation is there.
Yeah, definitely, sir. Definitely. Thank you, sir. And to Altaaf sir, right. In your humeral lengthening procedures, if the patient is a child, then how you take care of the growth of the child in lengthenings, humerus lengthening, because we are aiming for the equal length of both the humerus.
Yeah, of course. You see, it's not like it's not like lower limb lengthening that you need for ambulation. It must be equal. For humerus, you would accept any kind of just short of optimal.
Yeah, definitely.
So that's the concern. So if at an age group once they have presented with some kind of a shortening, so even if you have not achieved the exact lengthening, or if you were not able to match the future growth of it, you might not mind much.
So we can use that part also.
Yeah, because you for upper limb you need function rather than you don't need any kind of ambulation.
Because in upper limb length is absolute lengthening and absolute equalization of length doesn't matter that much.
So you go for lengthening only in those patients where you have gross shortenings, or where the patient is not able to reach his mouth. A dwarfus may have like if or in the other side, if the people are not able to reach for ablution. So that's the importance of lengthening in upper limb. Otherwise, you can have that. You can have suboptimal also.
Ravi, in upper limb, you can have up to 5 or 6 centimeters of limb length discrepancy.
Yeah, definitely. Actually, in one of the slides, sir has shown the equalization of both the humorals. That's why I asked that.
Yeah, because if you saw the lengthening happening event free, so you can go ahead. Anytime you feel that your lengthening is going to give trouble, so it's
because in upper limb usually we don't concern that much about the lengthening distance.
That's what I'm saying. So I think we go ahead with our next presentation. It's Dr. Shamsul Huda will be talking about trauma. We have had whole orthopedics so far, so let's have some trauma also.
Very good evening, sir. Thanks everybody for giving me a chance to speak on this platform. Today I'm going to talk in this IOA Ilizarov Subcommittee webinar about Ilizarov in upper limb trauma in general, use of Ilizarov. So in any primary complex trauma, orthopedic trauma, we usually see for the cause, this is usually high velocity trauma, associated problems may be shock, blood loss, head injury, maybe there, visceral, maxillofacial injury, maybe there. We have to take care of the ICU to see the multidisciplinary support. If there is no other injury, shall we go ahead for the surgery or not, or shall we go conservative? In the limb, we have to see that whether it is a comminuted compound fracture, whether there is a neurovascular injury, any compartment syndrome, bone or soft tissue loss, big gloved wound, amputation risk, infection. We have to give care, we have to wait, evaluate, slab, and X-fix in investigations. We first go for, before any surgery, we first go for grading for X-ray, for grading of fracture, plan of management, evaluation of healing, and CT for head injury, visceral injury, maxillofacial, and 3D CT for a degree of comminution, especially in intra-articular fractures for grading. We also go for CT, angio, color Doppler to see if there is any vascular injury. And at times you have to go for MRI for soft tissue and cartilage injuries, and ultrasound for visceral injuries. So for all compound trauma, whether we shall go for internal fixation or external fixation or Ilizarov, we go according to Gustlo's classification. If it is type 1 or 2, usually we go for internal fixation, and type 2 Ilizarov becomes an option. In type 3, when there is soft tissue coverage, we usually do X-fix, skin graft, flap, and then we can go for Ilizarov. In Gustlo's type 3B, where there is extensive soft tissue loss, periosteal stripping, bone exposed, bone loss, contamination, Ilizarov becomes a true indication. We can do a bone loose bone removal, a bone transport. In Gustlo type 3C, when there is open fracture, can be an arterial injury. It may need repair, or if limb survives, we have to see if you have to avoid the amputation or not. Then Ilizarov becomes definitive treatment. But for us, the Ilizarov surgeons, we can do Ilizarov in all the primary cases, either it be type 1 or type 3, because it is a really minimally invasive surgery with complete movements. So the regular indications are bone loss, exposed bone, compound for bad soft tissue coverage, infection, soft tissue, and bone comminution. Contraindication becomes polytrauma, head injury, multi-organ injury, neurovascular injury. Advantage we have with Ilizarov is that it gives circumferential support. Next post-op day, we can give full range of motion that we cannot usually go in all the other trauma cases, compound trauma cases. If we apply X-fix, the joint becomes stiff. So Ilizarov becomes an advantage here. Spring action of wire enhances healing, bone regeneration, soft tissue procedures. We can comfortably do, especially skin graft or flap, or even back at times can be done. There's no joint stiffness, use of universal hinges, joints. There's no joint stiffness. You can fix intra-articular fractures very well with multidirectional wires. It is a modular implant. Displacement, angulations, compression, distraction can be corrected gradually. Bone loss, bone transport can be done if needed. Patient can well for self-dressing, transportation can be done thereafter at 1 millimeter per day. The disadvantage is maybe it's a cumbersome implant. Patient compliance may be bad at times. Wires have not tensioned properly. Pains. It's a long duration treatment. It takes around from 3 months to 1 or 2 years. We have to counsel. Pin tract infection can be there. We have to take care. Skin and wound dressing is difficult if a patient goes home. Rail fixator or LRS is lightweight, easy to handle, no circumferential support. Pre-op protocol usually we have to operate in a trauma center with critical care unit backup. We always keep in OT, X-fix set, rail fixator, Ilizarov box, nail plate backup, and with the backup of plastic surgeon, vascular surgeon, neurosurgeon, and to arrange BT if needed. I always keep this Ilizarov box, my Pandora box, in my any trauma cases. Whether if I'm planning for interlocking NFC, there's a compound bleeding wound or pus, I can just readily convert to Ilizarov. These are the usual components that we use. In upper limb fixation for Ilizarov, this is the usual method of fixation, patient positioning for humerus, for radius. We always have to see for safe corridors before we apply Ilizaro. Safe corridors are longitudinal regions through which wires, pins can be inserted safely that contains neither muscular tendinous nor important neurovascular structures. These are the usual anatomy, neurovascular anatomy that every Ilizaro surgeon must remember by heart to check what are the path of the arteries, the nerves, and the tendons. If you're not impinging to the longitor biceps, you have to take care of axillary nerve. If you start from acromion, it is between 5 to 7 centimeter. We have to avoid the pins or wires. These are the usual levels for application of Ilizaro in upper limb and the arm. The first is coracoid process and neck of the scapula. Second is humeral head. Third is surgical neck of humerus. Fourth is upper third of humerus. Fifth is middle third of humerus. Sixth is lower third of humerus. And seventh is epicondyle. This is all given in text. These are the levers that we use to apply pins. We have to take care of the vascular structures. This is for the arm, and this is for the forearm. The usual levels that we all know. We have to be very, very precautious. We have to get a very good knowledge of this before applying Ilizaro in arm or forearm. Then it becomes easier for us. This is the usual scheme for application of Ilizaro in AP lateral position. We have to flex or extend at times, taking care of the vessels, nerves. So this is the usual configuration in upper limb of Ilizaro. You can see the different diagrams. Any young surgeons can follow these diagrams for application for proximal humerus, for acromioclavicular joints, for mid-shaft humerus, for distal elbow humerus, for elbow joints, for proximal ulna, for acromion fractures, for elbow fractures. We can use either wires or pins for this. For mid ulna or radius, for compound bone fractures, for wrist fractures. These are the different reduction techniques that we use with Ilizaro for reduction in OT. So just to show a few small cases here. This first case is of a distal and humerus compound fracture with compound bone. We can see the bone coming out, oozing out. It was also infected, so we cannot apply a plate or nail in this case. If you apply a X-fix, the elbow will become stiff. So in this case, I reduced the fracture first with evolutive wires. Normally we use pre-made frames, but in this case, I used evolutive wires to reduce the fracture well. Then over it, I applied the frame, and after that, we can see the patient can do full range of movements, full flexion, full extension. It healed very well in 3 months, and after 3.5 months, the ring was removed. You can see the very good healing and normal alignment of the bone, no deformity, full range of movement. Another similar case, compound humerus, distal humerus. Ilizaro was pre-made. Ilizaro was applied in this case. Healed very well. Soft tissue healed with movements of elbow. This is another case of distal and humerus button fracture. We usually, any orthopedic surgeon would go for either for X-fix or K-wires or open it up and place a T-plate. I used a minimal hardware in this case, just 1.5 rings and just 3 wires. Normally we apply 3 hinges in these cases, but I just applied 1 hinges. 3 hinges should be applied. So just with the principle of ligamentautaxis, with Ilizaro in any trauma, primary trauma even, we can do a very good reduction and movement of any fracture, intra-articular fractures. So this is after around 2 months, very well healed. The ring was removed and complete healing was there. Full function can be done with this. Another case of compound forearm fracture where the patient had compartment syndromes. I had to do NOT fasciotomy. So similarly, we cannot apply a plate over here. If we apply a second fracture, we have to wait for a longer time and then again apply Ilizaro. So I just applied directly after fasciotomy. I applied directly the Ilizaro rings in this case, and guide wires in the radius and ulna also. And after that, skin graft was done in this case. Graft healed very well. In this case, the distal ring has been removed. Radius is almost healed. Ulna is almost healing. So it will be removed in another 1.5 months. Another case of post-traumatic post-plating osteomyelitis of radius and ulna in a young boy around 17 years of age. A lot of pus was coming. So normally we can see a bad sequestrum in this case. Usually we remove the sequestrum and do a bone transport in this case. But the boy was very young. It will take a long time for bone transport. So I did a thorough debridement in this case and applied Ilizarov and gave compression. And after around 1 month, I did 3 cycles of piano accordion method, compression, distraction. And with this, no bone was removed, just except a few loose pieces. And we can see a complete, very good healing in this case. Without any transport was needed, the wires have been left for another 6 months. You can see the ring has been removed. Full movements is there. You cannot depict which hand was operated. So Ilizarov is a very good device in this case. This is another case of post-traumatic post-nailing infected non-union of humerus. These are the few cases I just did last week. This is still to be followed up. So I just removed nail, did thorough debridement. Ilizarov ring was applied. You can see full movements the 3rd day post-op. Another case of post-traumatic post-plating infective radius ulna case. You can see a non-union secretum was there. So loose pieces was removed. Ilizarov was applied, guide was applied, and ring is applied. These cases we have done recently. These are to be followed up. Another case of non-union humerus for more than 1 year. You can see the abnormal movements. I've applied Ilizarov ring and guide bar over here in this case. Full movements can be seen in this case. These are usual cases that you can do in proximal humerus with olive wires. The post-op protocol usually goes, we need to do a continuous counseling because patient's compliance is very important. For exercise is very important. The range of movement, rehabilitation is always important. So that if we're applying Ilizarov, we are doing minimally invasive implant. There should never be a stiffness in the joints. Daily dressing of the pins. We have to tend well the patient. For dressing transport, follow-up is regularly under 1 week, 2 weeks, 4 weeks, 8 weeks, 10 weeks, 12 weeks as required. It's a modular implant, can be adjusted later on after operation if you need. The ring is usually removed 12 to 24 weeks as required. So the take-home message here is Ilizarov in upper limb trauma is an excellent, minimally invasive device for fracture management. If proper follow-up done, it can be a wonderful device used as primary device without any joint stiffness, especially in cases of soft tissue damage. Other options available and can be decided on table. Good knowledge and expertise of Ilizarov is needed. It is a modular implant and can be adjusted post-op as required. Soft tissue heal well with Ilizarov on. Soft tissue flap, SSG, VAC is friendly with Ilizarov. Joint stiffness, interarticular fracture is not a problem if handled very well. So post-op rehabilitation in all these cases is very important. If we do well, we get no complication. We get a full range of normal limb. So Ilizarov can always be applied in trauma, whether it be primary, infective, post-traumatic, and any other cases. I always keep my Ilizarov box in any trauma case. So the hashtag goes for today's Ilizarov saving limbs and hope is life. These are my different patients from different regions, different states. These are my mentors who have taught me Ilizarov across the world. Thank you, my mentors. Thank you, everybody. Thank you, sir.
Thank you very much, Dr. Shamsulullah. It was a wonderful presentation, and there is no denying that Ilizarov has a definite and certain role in open injuries, and especially also in case of infections, where you can deal with a ring fixator rather than having any other implants. Any other questions from the panel?
I have a question.
Please go ahead, Dr.
Shamsul, in the case of Barton's fracture, I don't know whether I didn't see properly, but you just did ligamentotaxis and reduced the fracture and didn't fix the fracture at all. Is
Yes,
that
ma'am.
correct?
I didn't do them. Yes, ma'am.
Okay. So
Parapet was seen. Yeah, parapet was seen that it was well reduced, ma'am.
I know, but just holding the fracture reduced with one ring in the metacarpals and one in the proximal fragment, was that sufficient? I mean, you didn't have any loss of reduction? Why didn't you fix it?
No, ma'am. If I get a interarticular fracture also, then I put a radial allodiurnal also. But in this case, it does not need it. In this case, especially.
I think to me, Dr. Ruta, I thought that I also was concentrating on that. I thought that he must have actually reduced the fracture and then the ring was a neutralization one. To me, it looks like that because otherwise a deformity wouldn't correct that to a volar shift. It wouldn't just happen by an angular correction only. Naturally, because this was a distal radius, so he must have reduced it and then just applied the neutralization plate.
I used hinges for that. After applying rings, this traction I did.
Okay. Dr. Ravi, you wanted to ask anything?
Sir, just a comment actually what Ruta ma'am was saying, just to Dr. Shamsul, actually in volar and dorsal Barton fractures, I also don't prefer ki, just without any, how it's very difficult to reduce those fractures basically. Ligamento-texas don't work that much precisely in volar and dorsal Bartons. In basically intra-articular fractures, if they have the comminuted metaphyseal segments or intra-articular segments, then ligamento-texas works very well. But in volar and dorsal Bartons, it's very hard to reduce them, first of all, without opening it.
That's what I'm saying, because that's why I was surprised that a volar Barton, which is kind of a translational injury.
Yeah, definitely.
And so if the corpus goes with it, and simple angular correction wouldn't help it, unless you initially manually you have reduced it, and then
a little manipulation was done. A little manipulation was done before applying the rings.
Okay. Any other questions?
There is a question from YouTube. Let me see. It is from Dr. Yogesh Vegashia. If you will do rotation after regenerate, then it will give stress to regenerate theoretically. Is it affect regenerate significantly practically? For Vasu, sir.
Is Dr. Vasu around? I think I can take the question if Vasu is not available. So you don't have any issues with the regenerate. In fact, if you don't have a 6-axis deformity correction, then you may have to correct the angular deformity once the rotational deformity once you have corrected the angular deformity. So it doesn't have any effect on the regenerate because this all is a gradual process. Dr. Vasu is here. If you would like to take the question.
Yeah, I didn't get the question. I was disconnected.
The question was, there was one question from the viewer that if you have a deformity in the regenerate, a rotational deformity, if you tend to correct the rotational deformity of the regenerate, does it have an impact on the regenerate itself? Does it weaken it?
Yeah, I have two options. One, if I am doing a regenerate, I do it very, very slowly.
That's what my answer was. That it wouldn't matter that if you are
I can
still
derotate the regenerate. The other option is immediately after, the other option is immediately after osteotomy, I can derotate it and wait some extra days for distraction to be started.
Yes, I don't think there is any issue with the
so if I am doing rotational
correction. Since these are gradual process, so I don't think it should have an impact on its weakness or its in the strength of it. Any more question, Dr. Shamsul? Do we have any more question? No. Dr. Ravi wanted to ask.
Sir, in the Altaf sir, in treating acute trauma, basically compound fractures 3A, 3B in forearm fracture, forearm bones. So putting K wires or tense nails is how much effective it is, because to prevent infection.
It might be effective. It might be even effective in that. I don't think small profile instruments in
I'm a bit afraid of infection actually, because they are in spite of putting those wires and nails.
You see, it's quite a debatable issue that whether you should be using rings or external fixation or you should be using an intramedullary nail. This all can be debated. I don't think one can confidently say no, you go for nails, and one could say one could go no, you go definitely for
actually, my question is also to Shamsul actually also, because in every forearm case he used K wires and I think tense nails. They are
Ilizarov wires.
The Ilizarov wires. So don't you get any infection later on or?
No, because in these cases, if it is just a trauma, I just applied Ilizarov wire, there is no infection. If it is any infection, I do a thorough debridement, then only apply wires.
In every compound fracture, you use Ilizarov wires?
No, not in every compound, because that one case was the multi-segment, that was a segmental fracture, one case was there. That case was the infective case, Both cases I didn't get any infection.
In other words, Dr. Ravi, what you would like to say, if you are using intramedullary wires or nails, so you have already got some kind of a stability. In such a situation, would you use ring as a neutralization ring only?
Definitely,
because otherwise, because if you are apprehending infection with, then there is no fun. Then maybe either of the, Yeah, this is quite a debatable issue. I think this would
Yeah,
be a
because
separate discussion.
Using both the things simultaneously. That's why.
Yeah, maybe.
if I'm sure, if we are sure, it helps in taking out the rings a little earlier, especially in forearm.
And that's not really true in case of forearm, because the
Yeah.
nails won't prevent your rotational elements. So
Exactly.
may not be able to do away with those things. So anyway, I think let's move to the next lecture by our President ASAMI, Dr. Ruta Kulkarni. She'll be presenting about infected non-union of humerus, I suppose. Dr. Ruta, over to you.
Yes, I'll share my screen. So is it visible?
Yeah, ma'am, please go ahead.
Okay. So I'm just going to present a case of infected non-union humerus. Ilizarov is a really useful tool to handle infected non-unions, especially when all other modalities fail to unite the fracture and control the infection. So this is a case, this man had sustained this fracture 3 years before he came to me. And it was a closed fracture actually, and he was treated by open reduction and internal fixation, and he developed a nasty post-op infection. After that, he went to one orthopedic surgeon to another and underwent multiple surgeries. When he landed with me, this was the situation. He had this plate and pus was pouring. The bone grafting procedure was done twice, and all the bone graft came out as sequestrum one by one. So the skin condition was also bad, and the pus was not stopping at all. He was really a frustrated guy, out of work and out of money also. So the first thing I did was I did a thorough debridement. I tried to remove all the small bone graft sequestri, and I did thorough debridement and put in these chains of antibiotic impregnated beads. Then 3 weeks later, actually, I applied this Ilizarov frame. I applied 2 rings in the distal fragment, 1 ring in the proximal fragment, and 1 arch. So you can see the rings are a little crowded, and it was difficult to visualize the fracture site. But with oblique X-rays, I could do that. Within 1 or 2 months, the infection disappeared completely. But I was not seeing any callus. So I gave cycles of compression and distraction, as Shamsul was saying, accordion maneuver. So I gave 15 days of compression at the rate of 0.5 millimeter per day, rest for 15 days, and again distraction for 15 days. So this is one cycle of accordion maneuver. And I gave actually 3 cycles of this compression distraction with a little spaced out, with few weeks gap between each cycles. And then after 10 long months, I could see some callus at the fracture site. And this is when I removed this fixator. So though there is some amount of translation, there was good callus seen here. And this is 2 years later, he came with very, very good union and absolutely no infection. The infection was completely gone. And this was his function. So it was quite good. He had functional range of movements. So the point I want to make is, when all the modalities fail, actually, Ilizarov comes really handy to deal with very bad, nasty, infected non-unions.
Thank you, Dr. Ruta. Of course, there is no other remedy in such cases, and Ilizarov is always the rescue.
Yes.
In difficult non-unions, especially the infected, infected ones. Nice presentation, Dr. Ruta. Wonderful presentation. Do we have any questions for Dr. Ruta? So anybody else wants to make, since we have completed our presentations, we still have some time. We are well in time. We can have a couple of questions for all these topics we have covered. if anyone among the panel wants to have any kind of a discussion, any kind of a point before we wind up. Mangal sir, do we have any comment or any to conclude like what the presentations we have had? Because we have some minutes still left before winding it off. If we want to sum it up, or kind of anybody wants to have any comment or question.
No, I mean, my comment basically is that, you know, everything in the upper limb, also the Ilizarov works, it becomes a little more complex in the sense that the safe corridors, etc., are a little more complex, especially in the forearm. Then the areas where you can put pins in the humerus are also in that sense limited by the way the nerves move around. So you need to know your anatomy well. And therefore, I would suggest that, you know, people who start off should not
venture. They shouldn't
jump into upper limb to start with. Should have a good understanding of Ilizarov in the lower limb because it's relatively easier there, and then sort of graduate. And that's something that, you know, all of us have had our own. We show good cases, but I'm sure all of us have had our problems from that. So based on that, I would suggest that, you know, people should be careful about it. It's a wonderful tool, but don't just go into ki chalo ho jayega, you know, we have to put wires and nothing will happen. No, things can happen.
Of course.
Can I make one comment?
Yeah.
So after seeing Dr. Vasu's talk, I felt the message should be clear that whenever you can use other modalities, like doing a French osteotomy and doing an internal, go for that instead of going for Ilizarov, because doing Ilizarov for correcting such deformities is way more difficult than going for a simple French osteotomy or open procedure.
That's why, Dr. Ruta, I made it.
I have a comment there.
Yeah.
Ruta.
Yeah.
Have you ever seen an upper limb scar which is nice?
Well, scar is an issue, but
they are terrible. They are terrible. So therefore, that is one, especially for a male or female. I mean, I know generally people tend to say, oh, for a female, but even for a male, you see the scar. I almost always, if I can, I will do a forearm nailing. 2 stitches. Patient has to wear a brace for some time, but no scar.
Yeah.
The moment they have this rigid internal fixation, they will also have a very poor scar. I've never seen a good scar on the forearm.
Dr.
So
Mangal,
that is one important.
Yeah, I will take the both points. Like you see that Dr. Ruta is right in her words saying, like if you have a younger child that he has a smaller deformity, which can be managed otherwise. I think the point would be for a person who is not well versed should not venture it.
Exactly.
And
I agree with that.
Yeah. Dr. Mangal's point is very important in the sense that if somebody is comfortable, if somebody is good at Ilizarov, he can. That's an excellent tool for him, because for him it becomes really minimally invasive. This becomes a minimally invasive, but at the expert hands.
Yes.
Exactly. So the point I'm trying to make is that these are some of the reasons why you should aspire to learning the Ilizarov. I mean, look at it this way. I will do an operation for you. I will make your hand straight and I will leave a bad scar. And on the other side, I will do the operation for you and I will leave a minimal scar. So naturally, everybody has to progress. And this is one reason for, say, Ruta, who is an expert, to prefer an Ilizarov. That's what I'm trying to say. Not that everybody should do the Ilizarov. That's not my point.
Any final words from Dr. Viktor?
Yeah. Anyone has a comment about the cut olive wire for the radial head to prevent radial head from subluxating? Suppose if I have done that without a cut olive wire on the radial head, I'll definitely subluxate the radial head.
Yeah. That's why I made a point earlier also, Dr. Basu, that it is not the ring which will make things good for you. It is the understanding of the concept. That's that's the most important thing in Ilizarov. And I would take it that if 100% is Ilizarov, 95%, rather 91% would go for planning and the rehabilitation part.
Perfect.
And the surgery is only 5 to 10%. It's the concept, basically, how you manipulate the concept. Any final words from Dr. Victor, sir?
There's one question.
Okay, let's go ahead with the question.
Yeah, there's one question from Dr. Satish Nasari for Vasudevan, sir. Sir, how do you do dome osteotomy approach?
Dome osteotomy is not part of Ilizarov, no?
Yeah. He wants to know your approach, sir.
I do posteriorly.
Posterior approach.
I do posteriorly.
Right, sir. Right, sir.
And in normal deformities, I really find it good, basically.
Works well. Yeah.
No, but try to do a focal dome osteotomy.
Yes, definitely, sir, definitely.
Not the crying osteotomy.
Yeah.
And sir, Altaaf sir, just a last question I want to ask. Because in Dr. Victor's a lot of cases, I have seen the frames that were isolated thin frames. And is there any comment on stability of the frames, isolated pin frames versus the hybrid pin and wires in upper limb? What's your take on Dr. Victor, Dr. Mangal?
That was the top. That was what I wanted. That was I wanted to tell you finally. You see, if you had seen my cases, you will not see any key wire in upper extremity.
Yeah,
the rigidity is provided by the half pins, only by the half pins. I don't like K wire at upper extremities at all. Sometimes I place the K wires between the forearm bones, but I try not to make K wires for the upper forearm, and I never do the K wires for the shoulder. Never.
Dr. Ravi,
and the rigidity that it provides good rigidity if we place the half pins. You see, Dr. Mangal had shown monolateral frame. Was it rigid or not?
Yeah,
it was rather rigid.
I agree.
That is forearm. That is forearm. And for my understanding, there are only a few places on the shoulder, and there are only a few places in the forearm where we can insert the K wires, not worrying about the nerves and vessels. That's why I prefer shunt screws. Yes, I prefer circular external fixation because I can manipulate. And I'm Russian, and in Russia, you see monorails, they are rarely used. And the topic what I was speaking, it was 6-axis. That's why I concentrated on that. I had not shown my dwarfs. I make kilometers of lengthening of the upper arms in the dwarfs nowadays. And the things what I wanted for the future, I want this topic to be discussed because there are a lot of things which in different pathologies, they vary. Today, Dr. Mangal had shown us multiple hereditary exosclerosis disease. It is the topic to be discussed. Dwarfs, lengthening of the upper arm in dwarfs in achondroplasia patients. That is to be discussed. So the upper extremity is just, we had only touched it because you see, there was trauma, there were diseases, there were methods of lengthening and correction. So there are a lot of topics to be discussed later in future.
Thank you.
I agree with Victor that there are situations where, even a case like this, you can put in shank spins, right? You just have to be a little careful in terms of how you pass your. So under C-arm, you've got one pin over there, another pin perpendicular to it. You've got a perfect hold. Use a 6-axis, distract that out, and the whole thing heals without trouble. So there's just 2 pins in that small distal fragment. It's important how you put your pin in. You have to be careful about how you put your pin in. Don't cause thermal injury, etc., etc. But pins work pretty well.
And one more thing on the forearm, we can make separate, in some cases, we can make separate correction of ulnar and radial bone. Sometimes we do need to connect them, like it was in your case when you were bringing the radial bone with the ulna, with the regenerate of the ulna. But in some cases, when we have deformities of the separate deformities of radial and to the ulna, using the shunt screws, we can, using half pins, we can make separate correction and separate fixation. So we can provide rotation function. While we use KYs, we cannot do that. So that was the wide answer.
The only place where I think KYs are important is like Vasu showed, distal end of the humerus.
Yes.
There, the KYs with stoppers will have an advantage. You know, very small distal fragments, you can get very good fixation with KYs, and probably not as good with screws. That may be the one exception, I think.
Yes, the distal humerus is.
You agree, Victor?
Yes, I do agree. But
because you've got a large amount of.
In my practice, such cases that Dr. Vasudevan had shown us, they are very rare. Unfortunately, they are very rare. But I think in these cases of the distal shoulder, of course, this KY is essential because their bone is very thin and there is no structures there at all. So usually in such cases, we use 2 shunt screws that go in obliquely in the condyles and 1 KY between them in position 3-9 in frontal plane. So in these cases, yes, at the distal shoulder, it works well. But you see, in my practice, they are very rare because I'm mostly making a lengthening of their. Nowadays, my patient is mostly a achondroplasia patient or some sequela of osteomyelitis. So such post-traumatic.
And you are doing mainly. You are doing mainly pediatric, isn't it? You do mainly pediatric, isn't it?
90% nowadays are pediatric. Of course, I make something, some adult patient. I have such chance, I have such an opportunity, but most of them are children. In these cases, unfortunately, even I treat children, I see no cubity valga, cubity vara. It's very rare in my practice. That's why I have no big experiences in this area. But it looks good to make 1 KY and 2 shunt screws in the condyles.
Okay.
Hello. Okay. I think we have had a wonderful beginning to this IOA series of webinars. I would like to thank all the participants, all the faculty, and extremely thankful to all of you for the nice conduction of this Ilizarov webinar. So we'll inshallah try to do more and more and try to make it educative. And my idea would be that it should be made in such a way that it is helpful for the beginners and the middle rung experts, and then of course the advanced ones. So may I request Dr. Ravi to conclude and may say what of thanks to all of the faculty.
Thank you, sir. Thank you, Altaf, sir. So it was really a nice day. It's a really good beginning. And today we had a really nice discussion starting from Altaf, sir, who has so elaborately demonstrated all the spectrums of upper limb Ilizarov cases, followed by Dr. Victor, who has nicely explained that how the 6-axis correction systems can be useful and what can be their limitations as well. And followed by the excellent case presentations by Ruta ma'am, Mangal sir, and Dr. Samshul, and Dr. Vasudevan, who has so eloquently elaborated the deformity corrections by using the Ilizarov in upper limb. So I'm really thankful for all the faculty who have spared their valuable time for the presentation of their excellent lectures and for today. And I'm really thankful for IOA, who has given the ASAMI India great opportunity, and they have formed a Ilizarov Subcommittee, and they have really given us a good chance to show all the work that Ilizarov surgeons are doing in this nation. It's a really good opportunity for us. I'm really thankful for the all IOA team, Dr. Shivashankar President, sir, Dr. Navin Thakkar, our Secretary of IOA, Dr. Ramesh Sen, our Vice President President-elect of IOA, Dr. Atul Shrivastava, our Vice President of IOA. And I'm also really thankful in last, but not the least, Dr. Samshul, Dr. Ashok, who has provided a very good technical support. Without their support, we will not be able to go live with this. So in the last, I'm very thankful for all of you. Thank you. Thank you very much.
Thank you very much. Thank you.
Thank you. Thank you.
Stay safe.
Thank you, sir.
Thank you. Bye.
Thank you, colleagues.